The Leicester thing is a secret. You're not meant to tell anybody. I only lived there for 3 months. I've kept it secret until I'm 49. Now the world's... Don't tweet that the Scottish National Clinical Director is English, okay? Nobody knows. Only my mother knew that. Damn it. My secret is out. Thank you for having me. I'm delighted to be here, and thank you for choosing Scotland as your venue, and Glasgow, the finest city in the world, as the site for your conference. I'm sorry I wasn't here earlier today. I understand you had a fairly feisty question time. Where's Marshall? Is he in the room holding that? There he is, holding that together. I'm sorry I missed it. I didn't come because I wasn't invited to be on the panel. I understand my new cabinet secretary came and spoke to you yesterday. I hope she did well. The speech was good. Whether her delivery was good or not, you'll have to tell me later. But I hope she advertised Scotland to you. And that's what I'm going to do first.
Now is a place where hope calls home. Now is compassion and freedom to roam. Now builds bridges, now breaks down walls. Now is new thinking, now gives its all. Now is the heart, the soul and the head. Now is the town you'll want to paint red. Now makes the future, now bangs the drum. Now is the welcome for all those who come. Now is silence and breathtaking sights. Now bucks the trend. Now fights for rights. Now is new jobs. Now inspires youth. Now faces up to an inconvenient truth. Now more than ever is what the world needs. Now is the hope that our country feeds. There is no waiting. Scotland is now.
So there will be recruiters at both back doors. If you're not already in Scotland, you're very, very welcome. And we need all the help we can get, frankly. It's not quite nirvana, but it's better than some other parts of the world if you wanted to come. So please do look, particularly if you're looking for a job. But let me properly start here. This is Maureen. I met Maureen last week. Maureen is a heart attack survivor. She had a cardiac arrest on the day and the town you never want to have one. You could not make this up. Maureen had a cardiac arrest on Hogmanay in Edinburgh. So half the town is drunk, and everybody who's in the emergency services wants to be drunk. So you're in proper trouble. So she survives. She has a wonderful experience actually at Edinburgh Royal Infirmary. She has stents. She gets a very quick discharge. She goes home and she does really well. And then she has a horrible, horrible few weeks. And I don't need to tell a room of primary care advocates how difficult following acute care can be. She has some post-traumatic stress. She has struggling with going back to work. She doesn't know how she's going to look after her grandchildren. And she meets cardiac rehabilitation in its broadest sense. She meets cardiac rehab nurses. She meets Kim, who's her physio. She meets her primary care doctor, her primary care team. And she says, it gave me my life back. That's what she said to me last Tuesday. I spoke to her for 2 hours. And she described her primary care journey. And her primary care journey didn't look like a 7-minute visit. It looked like a team of about 15, I counted, who had some interaction with Maureen in that journey, following her very important and very crucial and very well done acute care. She described a 6-hour day at the end of her period of recovery where she wanted to go to Harvey Nichols. Are you familiar with this institution? It's quite a big deal in Edinburgh. It's a very bad story about Glasgow because Glasgow tried to get it and didn't get it. So she wanted to go to Harvey Nichols to buy her daughter perfume. She hadn't been on a bus for 30 years. She'd always driven into the town. And she was really worried she was going to collapse. She kept thinking she was going to have another cardiac event. And she did it. She went and bought the perfume, met her pal for lunch. It was a massive step about 5 weeks into her recovery. She chose to retire from the school she was an administrative assistant in. She put trainers on for the first time in her life. She said, I've never worn training shoes. She did a 9-week physical therapy course with that physiotherapist who you saw, and she looked after her grandchildren. That story, in short, I think is what integrated health and social care actually is about. It's about Maureen. So where have we gone wrong, if you think we have gone wrong? If you think it's all rosy, then maybe you should just go for coffee or wait for Victor. I'm not sure we've got it right. So this is Wolf and Johnson's article. It's a bit old now, it's 2005, but their fundamental premise was they were looking for the point at which more discovery harms. Does that make sense? So more investment, more resourcing of new stuff actually harms. They called it the break-even point. You might call it the sweet spot. Now, they're slightly radical. I think you can probably guess that I perhaps agree with them, but I wouldn't be allowed to say some of the things they're saying, so I've put them in quotation marks just in case you tweet them. Society's huge investment in technological innovation that only modestly improve efficacy by consuming resources needed for improved delivery of care may cost more lives than it saves. Health, economic and moral arguments make the case for spending less on technological advances and more on improving systems for delivery. Am I getting controversial yet? Let me illustrate it with a story. Now, if there are hematologists in the room, forgive me this simplistic stroke care thing. I'm a dentist, for heaven's sake. So, if you have a stroke and you survive, roughly speaking, all things being equal, you should take aspirin for the rest of your life. Roughly. I know it's not strictly true, but for the purposes of this story, stay with me. With me so far? If you give aspirin to 100,000 patients, using the NICE or the SIGN, depending on which country you're in, evidence-based guideline, we discovered this, we've known it for 3 decades, the drug is really cheap, it's perfect evidence-based medicine. We know how to do this. That stops 23,000 strokes. Got it? Even the GPs can do that calculation, surely. It took me 7 minutes, come on. So we managed to get that drug to 58% of the population who require it. That's the UK average for that piece of medicine. Whichever piece of medicine you choose to take, you could take asthma in 14-year-olds, you could take dementia care in 87-year-olds, you can roughly get half. We get half the evidence-based care we're meant to get. Now, I know you think in your practice and in your team you're better than that. You're not. You're just as rubbish as the rest of us. And every article in the Western world says you get about half the evidence-based care you're meant to get. So 58%, that's 13,500 fewer strokes. Fantastic, big success. That's really good. That's 13,500 fewer people having a second stroke after their first stroke. So what will we do? What is the healthcare system's solution to that problem? Well, you have 2 options. The sensible option is, of course, to have a fidelity approach. Fidelity is getting the intervention to those who need it. Got it? That's a health service design problem. It's a quality improvement problem. It's not a discovery problem. It is about getting to the 42% who don't get care. That might be because they're a single parent in a housing scheme in the East End of Glasgow, and your clinic's open from 11 a.m. till 11:05 a.m. every second Thursday of the month. And funnily enough, they don't come for their aspirin. Or you've set up a repeat prescription process where you have to go to the practice every 6 weeks to put in a request for the same drug you get the idea. That's a fidelity problem. That's the sensible approach. Let's try and fix the fidelity. What do? We try and make a better aspirin. That's what we do. We try and discover better heart medicines. We build cathedrals of cardiovascular care. We put our clever graduates, our clever trainees, our clever money, both pharma money and government money, into those cathedrals, and we make clopidogrel. That's what we do. And we give clopidogrel to the people who are already taking the flipping aspirin. And they have a 10% improvement in their stroke outcomes. That's good too. Evidence-based, it's in the guideline. That's the thing you should do. You also get 10% more side effects. It's much more expensive, and you still haven't got anything to the 42% who need it. Have I hit you over the head with the analogy quite hard enough? I agree with Wolf and Johnson. I think the actual investment out of health services redesign harms the populations we're actually trying to serve. So, is there a better way? Is there something we could do that might help us solve some of that? Well, it's not this. NICE has 17 guidelines about how to write guidelines. So the National Clinical Director of Scotland, he says, talking about himself in the third person, says, the next time you get one with more than 10 recommendations, chuck it in the bin. I got one recently, I'm not joking. It said, the cellophane wrapper. I often don't take them out the wrapper anymore because they just inflame me. So there was a covering letter on this clinical guideline. I can't even remember what it was for. The covering had 197 recommendations of things I had to do. The covering letter, I swear, said, best of luck with implementation. That's actually what the letter said. Best of luck with implementation. Their theory of change was hope. That was their theory. So don't buy laminators. Laminators are the enemy of change. Okay? This is what we do. We sit in a boardroom, we meet every 6 weeks, we form short-life working groups. Are you familiar with these institutions? They're neither short-life nor do any work. I'm on loads of them. The government is full of them. And we meet every 6 weeks and we publish a guideline, and it's really clever. We've got proper, actual nurses in the room helping us write them. And we come up with a thing and we send it to the country, and then we wonder why nobody did the damn thing. That's old-style thinking. W. Edwards Deming, some of you will know him. He's a cantankerous old bugger, but he's the father of quality improvement, the man who came up with much of our theory around quality improvement. This is Deming in a single slide to save you reading the dense textbooks. And in summary, Deming says, learn in the work. Go to the work. Go stand in the work and do it together. Test and modify in the work. It's not anarchy. You still get results at scale using vision and mission inside that overall process for NHS Scotland, NHS Wales, wherever you happen to be. But you learn how to do that change inside the work. We've learned in Scotland you need a big goal. And in Scotland, 5 million people, 1 integrated healthcare system, 14 territorial delivery systems, we can decide together. That's not possible in every country. And I genuinely feel in England it is more difficult to have that coherent approach just because of your size. But in Scotland, we can gather and we can say which hill we're going to take. It's not easy, but we can at least gather in one room. This week, we had the chief executives meeting. 22 chief executives and the executive board of the health service, and we meet in one room and kind of fight a wee bit and shout at each other. But at least we've got the same spreadsheet. That's not true everywhere. And you can choose a method, and that method has to have some kind of predictive, iterative testing. Now, our best example of that method in Scotland is the Scottish Patient Safety Programme. I could use others, and I'll finish if we've got time with a little quick story outside healthcare. But fundamentally, I'm just going to flash through some results that have been using that method. Iterative testing, a big goal, and a method, a quality improvement method that has now spread throughout the healthcare system in Scotland. This is HSMR, not the best mortality statistic in the world, but the best we've got. And that's a 9.2% reduction over the last 4 years, and we had a 16% reduction in the 6 years prior to that. The safety programme is 10 years old. That's 27,000 fewer than expected deaths in Scotland in the last 10 years. 27,000 fewer than expected deaths in the last 10 years. This is sepsis mortality. Again, it's a slightly tricky statistic. It relies on coding. Coding is not an accurate science, but it's the best we can do. That's a 21% reduction, principally in the implementation of the Sepsis 6 over the last 5 or 6 years. And then at a more granular microsystem level, this is pressure ulcers, one of the hardest harms to remove. We tackled it quite late in the safety programme. It's really, really difficult. It's multidisciplinary. It's often really frail, elderly. but this is 20 hospitals. We have about 21 decent-sized hospitals in Scotland of any big scale, and that's a 12% reduction in the first jump in that run chart, and then more recently, that's a 31% reduction in the last couple of years in total harm from pressure ulcers. This is our mental health safety program. We were the first country in the world to implement a mental health safety program across the whole system. Singapore has now gone second, and pieces of England are in this game, East London Foundation Trust principally. But that's a 20% reduction in patients self-harming inside mental health care. After the safety program began to gather momentum and graphs unusually started to go in the right direction, we weren't used to success, something weird had happened. It became difficult to get an infection in an intensive care unit. We began to close intensive care beds because we didn't need them anymore. Imagine such a world. And the people in charge of children and young people's services came to us and said, the stillbirth rate in Scotland is a global disgrace. It's double the Scandinavian average. We have evidence, we have all these guidelines, and we don't know why it's not falling. Nobody's implementing the guidelines. So we tackled it. We tackled it in a multi-agency quality improvement way, and we're down 20%. The two lessons in this graph, one is, isn't that clever? 20% reduction, it's fantastic. The other lesson is, if you want to show something at an international conference with a big graph, choose something you're really rubbish at. Because we were rubbish at it. We were really rubbish at it. The only people worse than us in the developed world were Australia, and they're still at 6%. They're still at 6 per 1,000 births. We're now approaching the Scandinavian average. This is multi-agency. This is not a health problem. It's a criminal justice problem. It's a drug and alcohol problem. It's a health problem. It's a social work problem. It's a school and education problem. And we brought all those people together in a quality improvement collaborative and worked together. We call it the Children and Young People's Improvement Collaborative. It meets in the SECC. We met every 3 months for 3 years in the SECC. 1,000 people working with children and young people across the whole nation. The same model we'd used for the Scottish Patient Safety Programme to drive that same system. Catherine Calderwood, our Chief Medical Officer, is a practicing obstetrician. She's the first CMO to see patients for 600 years. Isn't that quite interesting? All of the CMOs had seen patients prior to them being CMOs, I understand. Although I'm not sure that's always been true either in 600 years. But she's the first practicing CMO. And she went to, we didn't believe the number. Her and I, we saw the graph and genuinely we thought, nah, this just can't be right. Something's weird here. And she went and asked her colleagues back in Lothian in Edinburgh, and they told her there were more babies in the cots. So it was true. Let me finish here. This is moving outside healthcare. This is a town, the Scots in the room will know it, 15 miles from here. It's near where I was brought up. And this is what it still looks like. This is a recent photograph. It's post-industrial. It's very poor. It's got about 50,000 people in it. It's about, it used to have steelworks in it, and we ripped them out on a Tuesday night, roughly. We pretty much took the industry out of Scotland sociologically in 24 hours. And 40% of the population live in the most deprived zones in the country. We've applied the same methodology to a thing we call the 27 and 30-month review. Every kid gets reviewed at 27 to 30 months of their life. And the average for Scotland to get that review done, which is step one. Step two, of course, is to actually improve something, actually send them down a path that will do something for the developmental milestones. But you've got to get them in first. And in Coatbridge, which is one of the poorest towns in the country, they've managed to get that up to 81%. And in 762 kids, which was a sample we took, they are now meeting their developmental milestones at 12 months. That's astonishing in a town like this. That is GPs, social workers, play workers, teachers, police officers, prison officers, working together around the child and the family. That's the only way that works. And the primary care team have to be in that game. You might be the leaders sometime, often you won't be, but you have to be in that team. And this is how they describe having done it. We gave them a little bit of collaborative support, we gave them improvement methodology, but they engaged their health visitors and their practitioners. So where should you start? And this is my final little metaphor for you. It's tricky, it's hard, because you see these big scale numbers or the big policy decisions, the big things that you have no influence over. Some of you are in those big rooms, and you should continue to be in those big rooms. Many of you are not. Many of you are trying hard to finish your training or be a student or work in your practice. So this is the Bombay Golf Club. This isn't where you thought this was going, is it? The Royal and Ancient Golf Club in St Andrews sets the world global health rules. It decides the rules of golf every year, and it sends them out to the world, and every golf club in the world has to follow the Royal and Ancient Golf Club of St Andrews rules. Got it? If you have a local golf club, you are allowed local rules. So if you are the Bombay Golf Club, you can decide, if there's a river up the first green, you can say, if the ball goes in the river, this is what to do. St Andrews don't tell you that. Bombay Golf Club has a unique problem. It has monkeys. Sometimes the monkey will pick up the ball and run towards you. That's a problem. Sometimes the monkey will pick up the ball and run away from you. That's a good thing. Sometimes the monkey will run up a tree. That's a bad thing. Rule number 8 at the Bombay Golf Club, I swear, rule number 8 at the Bombay Golf Club, play the ball where the monkey drops it. I think it's pretty good advice. Play the ball where the monkey drops it. You can't fix those above you. You often can't fix those below you. You can't fix those around you. You can go in tomorrow, on Monday, whenever you next see a patient, and spend a bit of time asking them about their family. Ask them what matters to them. Try and fix that little circle of influence that's around you. Play the ball where the monkey dropped it. Thank you for listening. Yeah.